Yes, you can see my technological skills are unfortunately worse than my medical skills. This talk, for those of you who were here last year, is mostly a repeat from last year's presentation, but I have added a few sections based on feedback that we got about other things that people wanted to know. So I hope it's not completely a repeat for you. So the idea here is to talk a little bit about the basics of genetics, what the cancer risks are with BRCA mutations, how one might go about getting tested for those of you who are not tested, and then to talk about risk management for the cancers that are common with BRCA mutations, to talk a little bit of lifestyle. And what I've added is a little bit more about research opportunities and staying up to date and talking to family. So when we talk about genetic basics, I'm going to talk about what a gene is and what genes do, what specifically the BRCA genes are and what they do, what a mutation is and how do mutations increase cancer risk, and how are these mutations inherited. So basically, in our bodies, our cells have nuclei, which contain chromosomes. And the chromosomes are made out of DNA, which instructs our bodies how to work. These instructions are in the form of genes, which guide our cells to make proteins. In our cells, we have 23 pairs of chromosomes, one from each parent. And for those of you who are more visual learners, there's a cell with a nucleus, with chromosomes, and within the chromosomes, the genes. So the BRCA1 and 2 genes are what are called tumor suppressor genes. They instruct our cells to make proteins that are involved in the repair of DNA. And DNA gets damaged naturally from many causes, including outside sources like radiation, chemical exposure, but also just because our DNA is duplicating itself all the time, it can make mistakes when it's making copies. If our cell is unable to repair that damage to the DNA, it can lead to cancers developing. A mutation, it's like a spelling mistake in a gene, and it can result in either a protein not being made at all or a protein being made that doesn't work normally. So as I said, we have two BRCA, two copies of each gene in our body. And if you have one that gets damaged, you have a backup system by having this second gene. With a BRCA mutation, one of your genes already doesn't work properly. So then if the other one gets damaged, you lose the ability to make the proteins that help repair the DNA. BRCA mutations in general are not common. They occur in about 1 in 400 people in the general population. So this is just to show that again in a picture, that normal genes make normal proteins and mutated genes either don't make a protein or they make an abnormal protein. How are these mutations inherited? So when a sperm or an egg is formed, it contains one of each pair of chromosomes that's found in a normal cell. So half of the allotment in the rest of the cells. When an egg is fertilized by the sperm, the chromosomes from the egg match up with those from the sperm to make a full set. So an abnormal gene can come from either the sperm or the egg. So you can inherit a mutation from either your father or your mother. And similarly, if you carry a mutation, whether you're a man or a woman, there's a 50% chance that you will pass it on to a child. So this is showing again in a picture. We have a man who has a mutation, his partner who does not, and in their children, boys and girls, we end up here with one boy getting the mutation, one girl getting the mutation, and one boy and one girl not getting the mutation. So with each child, it's a 50% chance. In a setting like this, we tend to think that hereditary cancer is super common, but when you look at cancer altogether, the majority of cancers are not related to any familial or genetic problem. Only about 5 to 10% of all cancers overall are related specifically to a gene mutation, like BRCA, for example, that increases cancer risk. A further about 10 to 20% are what we call familial, where there's multiple small changes in genes combined possibly with environmental factors that increase cancer risk. And the rest occur by chance or related to environment, lifestyle, and things like that. And so that sporadic cancer, that's what the general population risk is that I'm going to talk about shortly. So as physicians, there's red flags for us that make us concerned that maybe a patient that we're seeing might carry a BRCA mutation. And these are some of the red flags. So seeing a woman who gets breast cancer under the age of 35 is concerning for a mutation. Women that get breast cancers that are not sensitive to hormones. Anyone who has an ovarian or fallopian tube cancer. Anybody who has breast and ovarian cancer in the same person getting both. A family where there's multiple people on the same side of the family with cancers that are related to BRCA. A man with breast cancer, metastatic prostate cancer, or pancreatic cancer. So these are all conditions that make us concerned that it might be associated with a genetic abnormality. Most of the time it's still not, but the likelihood is higher in these particular settings. And I'll just put as an aside that when I use man and woman, I'm talking about gender assigned at birth. One thing that we also know is that there is a higher risk in certain ethnic groups, so that if I see someone from a particular ethnic group that's at higher risk that has, for example, an ovarian cancer, they're actually more likely to be carrying a mutation than somebody from the general population that has an ovarian cancer. So what are the risks with a BRCA mutation? These are the latest numbers. So what I have there is the common cancers that are associated with the mutation, and then the two genes across the top, and the column on the far right is the general population risk. And this is what we call lifetime risk. And that means, what is the likelihood that you would get this cancer by the time you were 80 years old? So the big ones, as you can see, are breast and female breast cancer and ovarian cancer. So a woman who has a BRCA mutation, either one or two, has almost a 70% chance of getting breast cancer in her lifetime, compared to about 12.5% in the general population. Breast cancer is also increased in men, particularly with the BRCA2 mutation. It's 7% lifetime risk, which really is not a huge number, but it's enormously increased compared to the probability of getting breast cancer if you're a man and you don't carry a mutation, which is only 0.1%. For ovarian cancer, it's actually more common with BRCA1 at about 48% compared to BRCA2 at 20%. And again, much higher than the general population, which is about 1 to 2%. Prostate cancer is increased with both of these mutations, more so with BRCA2, and the numbers are a little all over the place there. So there's a big range in what the literature is reporting as the risk, with some studies even going up as high as 60%. And it's hard for me to understand where they get those numbers from. The important point is that it's increased. Prostate cancer is a common cancer in the general population as well, as common in men as breast cancer is in women. But the prostate cancer that occurs in mutation carriers tends to be more aggressive and more likely to metastasize than prostate cancer that occurs in people who do not have a mutation. There is an increased risk of pancreatic cancer, particularly with BRCA2 more than BRCA1. At about 5 to 10% with BRCA2, and again, much more common than in the general population. And we do think the risk ends up on the higher side, particularly when there's a family history of pancreatic cancer, because it's sort of, that's how the gene is manifesting itself in your particular family. And then there's others. So this year, gastric cancer, cancer of the stomach, has been reported to be possibly increased in both BRCA1 and 2. Melanoma has historically been reported as being increased in BRCA2, possibly in the 3 to 5% range, but some of the more recent reports aren't panning that out as a definite. And then there's this really small print that I talk to people about, is there's a lot of things we don't know. So as we get better and better at detecting people who have mutations, offering preventative surgery and screening effectively and treating cancers more effectively, more and more mutation carriers live their full natural life, which means we have an opportunity then to see cancers occur that are not that common. So people have survived their breast cancer or their ovarian cancer, and then, for example, pancreatic cancer doesn't typically occur until you're over 50, as opposed to the breast that might have occurred at 35. So how do you get tested for a BRCA mutation in British Columbia? So the most common way is that you get referred, or you refer yourself to the hereditary cancer program at BC Cancer. So you can self-refer, you don't need a doctor to do that. When you contact them, they will send you a link for what's called their online portal, where you answer a bunch of questions. And if you meet the current criteria for testing, you will be sent a requisition to generally have a saliva sample collected, which you then take to the lab. It gets processed, the results become available, and then if it turns out that you are a mutation carrier, you would then have an appointment to see a genetic counselor. So there are specific criteria that we currently use. Much of the ones on the list that I showed you of the red flags that make people candidate for funded testing, so it doesn't cost you anything. So for people who don't meet that criteria, and this is all talking about people who have not personally been affected by cancer, there is the option of paying for testing yourself. We don't recommend what's called direct to consumer. That's like 23andMe, because the accuracy is not that great. But there are a number of accredited labs that you can have BRCA or various other genetic mutations tested for around about $250 US. One of the other common ways that we see BRCA found, unfortunately, is that a patient, for example, gets ovarian cancer and their oncologist, their cancer doctor, orders the BRCA test because of the concern that the cancer might be related to BRCA. And it's important because the drug choices are different for cancers in BRCA carriers than in those that don't carry the mutation. So one of the important things that we like to talk about is, how are you going to manage this risk? You know, a lot of people think, why would I want to know that I've got something bad if I can't do anything about it? So it's important to know you can do things about it. So I run what's called the Hereditary High Risk Clinic at BC Cancer. And we see patients that are mostly referred by the genetic counselor. I see women only, and they either have a confirmed mutation or they're at 50% risk and they're untested. So for example, a mother has the mutation, the daughter isn't sure she wants to know, but we'll still see her, and we do still offer screening until she decides to be tested or not. The reason it's not meant to be discriminatory that we see women has to do with the testing and referrals that are needed, which is different than for men. And I'll talk about what screening we do for both. We see a number of patients also that are referred by their oncologist once they've completed treatment for the cancer that they had that identified them as mutation carriers, and now they don't need to be followed by the oncologist anymore. So they send patients to us for ongoing follow-up. We offer both telephone consultations or in-person consultations for in-person for people who live in the immediate Lower Mainland, and telephone for everybody else in BC and in the Yukon. And similarly, follow-up appointments are by telephone or in person, depending on where you live. And what we do at those visits is we take a full medical history, because our recommendations are going to vary depending on a person's age, their other health factors, and their wishes. And I review the risks that would have been, that I've talked about here, that were told to them by the genetic counselor. We talk about the options, and then we either arrange screening or surgical referrals, depending on what the patient wishes. And then we do follow up every year. So we have a number of different options for how we're going to manage increased risk for women with breast cancer. So one of the options is increased screening, which I'm going to talk about on this slide. So currently, we recommend that BRCA carriers have a mammogram every year from the age of 30 until they're at least 74 years old. So that's quite different than the general population, who gets a mammogram every other year from 50 to 74. After 74, we ask that the family doctor who would be seeing the patient, at that point, evaluates the person's health. Are they healthy enough that they're going to benefit from screening? And I just want to put in a small point here. Often people are confused about what it means when we talk about screening mammograms versus diagnostic mammograms. So the initial mammogram that's done through the screening mammogram program, and the initial mammogram that's done if your doctor refers you to a hospital to have a diagnostic mammogram, are exactly the same things. So you don't need to feel that because you have this mutation, you have to have a diagnostic mammogram. The only people that have to have diagnostic mammograms are people who have breast implants, people who have had a previous breast cancer, or people who have on a mammogram or other imaging been found to have an abnormality that's still being worked up or followed. So with the diagnostic mammogram, they can do some extra images that give a little bit more information. But generally, our patients are enrolled in the screening mammography program for their mammograms, which gives you an annual automatic recall. They send you a letter, remind you to book your appointment, and they also automatically arrange the next investigations if the mammogram is abnormal, and it's actually much faster than doing that through the diagnostic route. We also do annual breast MRI from age 25 to 70. So MRI is more sensitive so more able to detect cancer than mammogram is. Mammogram is better for identifying what's called non-invasive cancer, because non-invasive cancer has calcium spots in it, and those are better seen on mammogram than on MRI. What I talk about there, that we have less false positives. So false positives means you see something and it turns out that it's nothing. So we see more things like that on MRI than we do on mammogram. We also recommend, or do, depending on whether we're seeing the patient or not, an annual physical examination. We recommend that women, what we call, be breast aware from age 18, which doesn't mean you have to do a formal breast self-examination every month, like some of you may have been taught many years ago, but it means you need to pay attention to them. You're in the shower getting washed. You need to take a moment, pause a moment, and pay attention to what you're feeling. Screening does not prevent breast cancer, obviously, but because it allows us to pick up cancers earlier, it's associated with better survival rates. So people who are screened compared to not doing any screening have a higher survival rate than if you don't screen. This is just so you can have an idea of what we're seeing. So these are mammograms, and they're just showing what a lump looks like on mammogram. The one on the far left, it doesn't look that worrisome. It's kind of round and reasonably smooth, but it's a little irregular. The one in the middle is very suspicious. It has what we call a star-like pattern or a stellate pattern. It's going like this. That's because the cancers draw the tissue in. And on the far right is what we see calcifications. And they're kind of going along a line because they go along a duct, which is where the cancer originally forms. So in these mammograms, you can see those cancers pretty well because these mammograms are in what we call not dense breasts. So some of you who have been having mammograms already, you'll get a report from the screening program that says whether you have dense breasts or not. And what it means when you have dense breasts on mammograms is that the breasts look white as opposed to gray. So you can imagine that it's hard to see a white lump in a white background. So mammography is less good in dense breasts. Young women tend to have dense breasts. That's why we start MRI earlier than we start mammogram, because you're not likely going to see much doing a mammogram in a 25-year-old. The next picture is what a breast cancer looks like on MRI. There's a computer program that they use that creates the color. So red spots are cancers on mammogram, blue spots are not, and everything else is normal. So it's actually much easier to see the cancer on the breast MRI than it is on the mammogram. So what about if you just don't want to do just screening? So there is an option to have preventative surgery for breast cancer. So that's called prophylactic mastectomies. And that can be done with or without reconstruction. It's completely a personal choice, whether you choose to have your breasts reconstructed or choose to go flat. Reconstructive surgery is covered by health insurance. It's not considered a cosmetic operation. That surgery reduces the risk of developing breast cancer by more than 90%. It is not 100% because you can't physically remove every single breast cell. They don't actually look any different than the fat, and you have to leave some fat on the back of the skin so the skin doesn't die. But really, with a 90% reduction, the risk of getting breast cancer after you have a preventative mastectomy is actually lower than the general population's risk of breast cancer. So you actually become low risk for the breast cancer once you have the surgery. We don't do any routine screening with mammograms or MRI after surgery. We still recommend a yearly physical examination with investigation of any new lumps that are felt, usually with ultrasound, sometimes also with mammogram, and that the person, again, pay attention to their breasts or chest and see their physician if they feel any new lumps. When we compare screening versus surgery, because patients will say, well, what should I do? The main benefit for the surgery is about reducing the risk of getting cancer. So you don't have to go through the experience of being told you have cancer, likely requiring chemotherapy, and then worrying that it's going to come back. Generally, there hasn't been much evidence that it significantly improves your survival. So what that means is that if I took 100 women with BRCA mutations and they had mastectomies, and I took 100 women with BRCA mutations and they chose not to have mastectomies, and we followed them until they were 80 years old, pretty close to the same number of women would be alive in each group. Some would have died from heart disease and other causes. And a large number of the women in the screening group would have got breast cancer, been treated, and be cured of it. So the decision is it's not about life or death. It's about what experience you want to have in your life. There were several papers looking at mathematical models, which suggest, because not everybody is cured of the breast cancer that they get, that statistically there should be a small survival benefit, particularly if you have mastectomy, say when you're 25, when you really have that full lifetime risk of breast cancer ahead of you. We didn't see that in studies until very recently. There have been a paper that showed a possible small, again, 2% survival advantage to having mastectomy versus screening if you were BRCA1. And that's because of the type of cancers that BRCA1 carriers get compared to BRCA2 carriers. But it's not for sure. The third option, besides just screening or just surgery, is what's called chemoprevention. And that's taking medication to reduce breast cancer risk. And there are a number of different medications, but in the general population and in BRCA carriers who have had a breast cancer, they reduce the risk by 50% of developing a new breast cancer if you take them for 5 years. So if your lifetime risk was 70%, now your lifetime risk would be 35%. And that benefit lasts. Different drugs, some are only okay if you're postmenopausal. They each have different side effects. Again, it's a personal choice about whether you want to do more than just screen. I wanted to talk a little bit about things that might modify risk, because when you read about breast cancer in general, not specific to BRCA, there's a lot about things like when you first got your period, when you went into menopause, did you take hormones, how many pregnancies did you have, when did you get pregnant, and when did you nurse? So people do ask about, is it beneficial for me to nurse? Is it dangerous for me to get pregnant because I'm going to have all these hormones going on? Is it safe for me to have in vitro fertilization, for example? So the literature, unfortunately, is a little bit all over the place. It does appear that having more than one pregnancy reduces the risk of breast cancer if you're a BRCA1 carrier. Weirdly, having the pregnancy later reduces risk, and that's different than in the general population. There is a suggestion that just having one pregnancy and not more might increase risk. So it's a little bit here and there. I tell people, like, you shouldn't make your decision about whether you want to have a child or not based on breast cancer risk, because we don't have enough to go on there. For sure, though, we do know that breastfeeding in BRCA1 carriers does reduce risk, and you get a 32% reduction in breast cancer risk just for nursing for 1 year. And it does seem that the longer you nurse, the more protective it is. For BRCA2, I haven't put anything there about nursing because some studies say it's good and others say there's no evidence, so I didn't put anything down. Pregnancy may increase breast cancer risk unless you have more than one child when you're under 40, or altogether more than 4 children. So again, I encourage people to choose to have their children if they want to have their children, and nurse based on all the good things for nursing, and know that there's no evidence that you're really harming yourself significantly. And one of the things I like to put in context is, if we're talking about a 70% risk of something, and something else increases that risk by 2%, it's increasing your risk, say, from 70% to 72%. That's not a big difference. It's not like if your risk was 25% and now it's 50. Okay. One of the other things that comes up is, like, what if you have a diagnosis of breast cancer and are found to be a BRCA carrier, or you're a BRCA carrier, you're having screening and you're found to have a breast cancer? So you do not have to have both breasts removed. Most people do, but you don't have to. There is a higher risk of getting a cancer on the other side in mutation carriers than in people who do not carry a mutation. But the treatment for breast cancer that you get, for example, like taking tamoxifen or having your ovaries removed as part of your breast cancer treatment, reduces even that risk of getting another cancer. So you don't need to feel obligated. And I like to mention that because I find that the message that tends to go out from both oncologists and family doctors is, you should have your breast removed. And why aren't you having your breast removed? So you don't need to have your breast removed. So what about male breast cancer? So we recommend that men be breast or chest aware, so that if they ever feel a lump, they see their doctor. They should have a physical examination by their doctor yearly from when they're 35. And then there's been some suggestions that maybe mammograms should be done as a baseline at 40, maybe they should be done annually from 50. Clearly, that only applies when there's enough tissue there that you can actually do a mammogram, but it's not a definite. And it's sort of interesting to me, even when they talk about that, because we don't offer annual mammograms to women who have a 12.5% risk, but now we're talking about annual mammograms for guys who have a 7% risk. So it just doesn't really make a lot of sense and not consistent in the care that we're providing to people. So I'm going to move on to ovarian cancer. So the big problem with ovarian cancer, unlike breast cancer, is we do not have any effective screening. And this has been studied a lot to see whether blood work or pelvic ultrasound allows us to detect ovarian cancer early. It does not. And ovarian cancer, it grows very silently with kind of pretty vague symptoms. So by the time most women are diagnosed, the cancer is usually quite advanced. And historically, the cure rates were bad. The only thing that we know currently for sure that reduces the risk of developing ovarian cancer is taking birth control pills for more than 5 years. And that reduces ovarian cancer risk by 50%. But going back to the numbers that I mentioned before, if you're BRCA1, you have a 48% chance of developing breast cancer. Even taking that in half still leaves you with a very high risk of developing ovarian cancer. And similarly, for BRCA2 with a 20% risk, you're still looking at a 10% risk of developing a cancer that's quite lethal that you can't screen for. So the current recommendations is that BRCA1 carriers have preventative removal of their fallopian tubes and ovaries between the ages of 35 and 40 once they finished having their family. And for BRCA2 carriers, the recommendation is 40 to 45. And the reason that it's different is because we don't tend to see ovarian cancer under the age of 45 in BRCA2 carriers. So it tends to occur a little later than it does start to occur in BRCA1. That surgery reduces the risk of developing ovarian cancer by at least 90%. And unlike the mastectomies, with which I said there wasn't a survival benefit, this surgery is associated with a significant survival benefit. So you're much more likely to be alive when you're 80 if you prevent your ovarian cancer, because it's a bad cancer and we don't have great treatment for it. If you have your ovaries out before your natural menopause, it actually reduces your breast cancer risk by about 50%, maybe a little bit less for BRCA1 because BRCA1 has more non-hormone sensitive cancers, but beneficial for both BRCA1 and BRCA2. There's disadvantages. So going into menopause before you were due to go into menopause has some long-term potential consequences for your bone and your heart. And in order to try and mitigate against those, we actually recommend that women who have premenopausal removal of their ovaries go on hormone replacement until what would have been their natural age of menopause at about 50. Now, our next guest speaker is going to talk about some current research study going on where we're looking at whether or not ovaries need to come out. So in doing these preventative operations on BRCA carriers, they didn't find early cancers on the ovaries. They only found early cancers in the fallopian tubes. So we believe now what we've been calling ovarian cancer and still call ovarian cancer is actually probably fallopian tubes cancer as where it starts. What we don't know now is whether just removing the fallopian tubes is enough. And that's the study that Dr. Kwon is going to talk about. So for pancreatic cancer, the main thing is not to smoke. So smoking significantly increases pancreatic cancer risk. We have a little bit of screening for pancreatic cancer. If you don't have pancreatic cancer in an immediate family member like a parent, sibling, aunt, uncle, that kind of level of relationship, then all we recommend is that you have screening for diabetes every 3 years from the age of 40. Now, most of the time when people get diabetes, it's not because they have anything growing in their pancreas, but with this mutation, when you develop if you were to develop diabetes, then we would do a scan of your pancreas to make sure there wasn't something growing in your pancreas. If you have that family history, though, in addition to doing blood work every year now, we add some imaging with an MRI of your pancreas 1 year, and the following year, what's called an endoscopic ultrasound. And that's where a doctor puts a camera into your stomach through your mouth. The camera has an ultrasound on it, and they can look at your pancreas through the wall of your stomach and see whether there's anything growing in it. And we generally start that screening from age 50, but earlier if there's a earlier pancreatic cancer in the family. So we do take your family history into consideration for when we're recommending screening start. For prostate cancer, as I mentioned, it's different in BRCA carriers. And I think that's important if there are any men in the audience, or for your partners, or family members that may be mutation carriers. The general message that comes out about prostate cancer for the general public is this is a nothing cancer, right? You're never going to die from this. You'll die with prostate cancer, not of prostate cancer. So that is not the case with BRCA. We see prostate cancer younger. It tends to be more aggressive, and the prognosis is not as good. So higher chance that it comes back, higher chance that it shows up elsewhere in your body. The only screening that we currently recommend is a rectal examination to see if your doctor can feel a lump, and having blood work called a PSA, which is a prostate-specific antigen, every year from the age of 40. Currently, the prostate-specific antigen you have to pay for. In British Columbia, it's $40. I do like to talk to people about what we call lifestyle modifications. So there's a lot of cancer in our population, right? Half of people are going to die from breast cancer. And we strongly believe in the medical and research community that a lot of those cancers are influenced by what we do or what we don't do. Whether or not these factors also modify risk in mutation carriers, we don't know for sure. But most of these things are not good for you anyway, so it's still worth talking about. So smoking is associated with a higher risk of breast cancer. So women who smoke in the general population are more likely to get breast cancer if they smoke for more than 10 years. And they also don't do as well. So cure rates are not as good if you're a smoker and you get breast cancer. Smokers are twice as likely to get pancreatic cancer in the general population as non-smokers. And if you are a smoker and you get prostate cancer, you're more likely to die from your prostate cancer than if you're a non-smoker. So you should not smoke. This is not a new message, I'm sure, for anybody who's ever watched the news. It's not good for you. There's been more recently talking about alcohol and how much is safe to drink. So there's a current recommendation for women to drink under 4 drinks a week. Women who drink more alcohol have a higher risk of developing breast cancer in the general population. Being overweight is associated with increased risk of a number of different cancers. I'm only going to talk about the ones that are pertinent to the BRCA. So for every 5-point increase in your BMI, so BMI is a height weight calculation, there's a 12% increased risk of breast cancer in women postmenopausally. So it's specifically bad to put on weight after menopause. It's higher breast cancer risks. Also, women who get breast cancer and are treated have a higher risk of recurrence if they're overweight or if they gain weight. And that has to do with how your body creates estrogen in your body. It's actually created in fat postmenopausally. from other chemicals that are produced in your adrenal gland. So the more fat you have on you, the more estrogen you have in your body. Being overweight is associated in the general population with a 20% higher risk of pancreatic cancer and a higher death rate from prostate cancer. So trying to achieve more ideal body weight is good as far as cancer risk management, and of course also good for other health issues. In the general population, regular exercise, so that's the 150 minutes a week of moderate exercise that you've likely heard about, is associated with a lower breast cancer risk, and it's also associated with a lower risk of death if you develop ovarian cancer. Vitamin D is more recently become a little questionable. So these studies are not about whether taking vitamin D reduces your risk. This was about were people who were vitamin D deficient have lower cancer or higher cancer risks. So this showed that people who had adequate vitamin D levels had a lower risk of breast cancer than people who had low vitamin D levels. There was also some studies that suggested that there might be a lower risk of ovarian cancer if you were not vitamin D deficient, and a lower chance of dying, and possibly also a lower chance of mortality, so dying from prostate cancer. More recently, some of the literature says that's not panning out. And those are difficult studies to do because you're relying, on people telling you what they take and what they haven't taken, and the accuracy of blood tests as well. So this is a new that I've added since last year's talk. A lot of people, do ask about what's happening in the research. We've been doing the same thing for these cancers as in our clinic since it started in 1997, screening surgery. So there's a website called FORCE. It's from the US, called Facing Our Risk. And I put the link there. They have a really amazing list of all of the research clinical trials that are going on related to hereditary cancer. So not necessarily all BRCA, but lots of stuff. However, it is primarily US based. And if a study is based in the US, usually you need to be in the US to enroll in those studies. But some of the studies are multinational, so they're in the US, Canada, and Europe. And if one of those studies is running in BC, you could enroll in it. If it's running in another province and you were willing to travel to that province, you could enroll in it. So I've divided the next section into just to tell you about the types of research that's coming downstream in 3 categories: prevention, detection, and treatment. So in the prevention field, these are the kind of the studies that I pulled out of that list off the FORCE website. So there is a vaccine that's being investigated to prevent what's called, in BRCA1 carriers, what's called triple negative breast cancer. So that's breast cancer that's not hormone sensitive and also doesn't have something called HER2. And that's the most common breast cancer in BRCA1 carriers. There's a study actually looking at aspirin for breast cancer prevention, which is kind of interesting. As an aside, aspirin has been shown to reduce colon cancer risk in people who are at genetic risk for colon cancer. So there's something about what aspirin does to how your cells grow. There's a couple of other drugs that are being studied. These are called monoclonal antibodies to prevent breast cancer in BRCA1. There's a study comparing a drug to tamoxifen to prevent cancer. I mentioned tamoxifen as one of the drugs that we do prescribe now to reduce breast cancer risk. So it's trying to see whether this other drug is effective, which mostly these investigations are done not only to see if they're effective, but effective with less side effects. And then, as I mentioned previously, what's called this study to look at whether removal of the fallopian tubes alone results in a lower ovarian cancer risk, and by how much, which is called the SOROCk trial, which Dr. Kwon is going to talk about. in the early detection, trying to look at ways other than mammograms and MRIs to detect cancers and to see whether there's any way to detect ovarian cancer. So one of the studies is looking at what's called uterine washing. So that's sort of putting a fluid into the uterus and collecting what comes out to see whether you can detect ovarian cancer. That's being done in conjunction with women who are having the preventative surgery, because some of the women who have preventative surgery are found on their pathology specimens to actually have cancer. So they want to see whether in those that had cancer, they could see signs of the cancer in these washings. There's another study, which you might have heard is called liquid biopsy. That's basically looking in blood samples to see evidence of what's called circulating DNA. So cancer cells are kind of loose and they can release some of their DNA into your bloodstream, and they're trying to see whether having regular blood tests would allow you to detect this. So if you found this, then you would have other testing done to see whether there was a cancer. For pancreatic cancer, they're looking at comparing a number of different things, looking at blood tests, looking at MRI, and also looking at collection of fluid samples from the duodenum. So the duodenum is the part of your intestine just after your stomach, and your pancreas releases liquid into your duodenum that has the enzymes that help you digest. So this is collecting that fluid from the duodenum to see whether you can identify anything that would lead you to detect a pancreatic cancer, maybe before it was big enough to see on any of the imaging. For prostate cancer, what they're looking at is whether screening with MRI allows earlier detection of prostate cancer than doing blood work and the rectal exams. There's a lot of activity looking at new therapies. So the big one that came out a number of years ago was a drug called PARP inhibitors. And PARP inhibitors are extremely effective at treating metastatic, so cancer that is spread, that occurs in BRCA carriers, and also in reducing the risk that your cancer comes back. So you have a breast cancer, you get chemotherapy, which is the standard treatment, and then you go on this PARP inhibitor for a year, and the study showed if you did that, there was a lower chance of your cancer coming back than if you didn't take the PARP inhibitors. So those are used routinely now. There's another drug that's being added to chemotherapy for ovarian cancer in people who have recurrence, and we do use PARP inhibitors also in ovarian cancer in BRCA carriers. There's studies looking at monoclonal antibodies for patients who have ovarian cancer recurrence, and also another category of drugs called immune checkpoint inhibitors in breast cancer. This is all sort of specifically in BRCA mutations, because the cancers are different than cancers in non-BRCA mutations as far as what's gone wrong there and how you might treat it. The last thing that I wanted to just talk about briefly, and then I'm almost done, is about talking to the family. So, finding out that you're a mutation carrier is generally pretty shocking, though some people, because of their families and everybody's been already found to have a mutation, are not so surprised when they have it. And it can be really hard at the beginning to, if you're the first person to be in your family to be found to have a mutation, to share that information with your parents, because one of your parents gave that to you, so they're going to feel bad, with your brothers and sisters, and also obviously with your children. And when we talk to, we have a program of following up patients who are mutation carriers, and we ask about communication with family. And most people are pretty good about talking to their brothers and sisters, their parents, and ultimately their kids. We're less good at talking about to the extended family, but it's super important that that information about the potential risk goes out to everybody, because you can prevent cancer, right? By having preventative surgery, if you know you're a mutation carrier. If you don't know, you can't prevent it. And unfortunately, if you don't know and you get cancer, you could die from that, and you really had an avoidable death. So by communicating with your extended family, you're actually potentially preventing somebody from dying. It's still really hard. And we have now what's called shared decision support. So that means the genetic counselor that is involved with your care, with your permission, can be the one to reach out to the extended family with this information. It's anonymous. They don't have to say that you're the one who has it, but more that this has been identified in a family member, and this person is a candidate for testing. So if you have family that you don't speak to, or family that is not local, that you have challenges in communicating with, we can help. This is a field that changes all the time. Like I said, gastric cancer was this year's talk. Last year it wasn't. So the risks that we know about change, and also the management recommendations change, and it's hard to keep up. And we do update patients whenever we have new information. So for another mutation, for example, I just sent out an e-blast to all of my carriers, because actually they don't need to do something now that we thought they needed to do. So we do keep you informed. But the same website that had the research on it, the FORCE website, they have a gene-specific newsletters. So you can sign up as a BRCA carrier to get updates in their newsletters about your gene, the risks associated with it, risk management, and research. Again, with the caveat, it's US specific. They do things a little bit differently than we do. And that's there on that slide is the link to get you to that genes by name page. And then you would pick your BRCA mutation and get regular updates from them. And now I'm open for questions.